he will talk about the modern health literacy approach to advanced health promotions and health service development in Indonesia. Before we begin with the seminars, we will invite the Vice Deans of Faculty of Public Health to give some opening remarks for these seminars. Ibu Sabarina.
Selamat pagi Ibu dan Bapak sekalian. Assalamualaikum warahmatullahi wabarakatuh. Good morning, Professor Richard Osborne and Mr. Roy Butterham. You are the guest lecturers, the prominent guest lecturers in this very beginning of the semester. First of all, I would like to thank from the Faculty of Public Health of your collaborating and participating in this very beginning of the seminar. Terima kasih Ibu dan Bapak sudah hadir pada pagi ini. Pada pagi ini kita tadi seperti yang disampaikan oleh Ibu Rita, kita akan mendengar satu kuliah berjudul Modern Health Literacy Approaches to Advanced Health Promotion and Health Services Development in Indonesia. Ini suatu pendekatan yang harus kita pelajari. Jadi ini health literacy dan ini juga modern. So this is an approach that modern approaches. Is this right? Yes, and we are keen to learn it from you. I believe that both of you have so many experiences in these approaches. So we would like to know it and whether I think this is very important for us to implement it in our implementation and our program and our activities, because the health literacy is an approach. So it is a universal methodology, and it can be applied into many problems and many programs. So on behalf of Faculty of Public Health, the Dean apologizes that she could not attend this very important meeting, a very important lecture. So I would like to say that the guest lecturer, Professor Richard Osborne and Mr. Roy Butterham, are welcome to give their speech and their lecture, and this lecture is opened officially. So thank you very much. Thank you, Mr. Professor Richard Osborne and Mr. Roy Butterham.
Thank you, Ibu Sabarina. Before she leaves, our university will give a token for appreciation for Deakin University and also for both of you. So please come, Pak Richard.
Oh, wow, this is fantastic.
Yeah, and also for both of you personally, so Pak Roy and Pak Richard. Okay, and then we will have pictures together first before we begin with the seminars. Yeah. Okay, come on. Yeah, Pak Richard, maybe you can sit here. Yeah, and we have formal pictures first.
Okay.
Come on, everybody.
Okay. Okay.
Ya, sini. Yang undergrad boleh di sini. Duduk di sini aja depan. Ayo Pak, mau nggak Pak? Ya.
Is it okay? Oh, so.
Oh ya.
Okay. Okay.
Ya, Bu. Ayo Pak, Ibu, Bu, dari FK, Bu, Ibu. Yuk.
Okay.
Thank you very much.
You're welcome.
Terima kasih. Thank you very much, Ibu Sabarina, for the opening remarks, and then we'll begin with the seminars, and Pak Richard and Pak Roy will lead these seminars.
Good morning. Thank you for the very kind introduction. It really is a very great honour for us to be here working with you and for us to be able to share our knowledge and our insights that were gained from a range of countries around the world. Very warm introduction, and hopefully this is the start of a whole wide range of collaborations between the University of Indonesia and Deakin University and many other universities around Indonesia and around Asia. The presentation today is around modern health literacy approaches to advance health promotion and health services development in Indonesia. We're both obviously not Indonesian, so we don't have much expertise in Indonesia. We're methodologists. So we are very much interested in method and coming to places not to be the expert, but to share method of how to uncover good things, smart things, useful things that will help people on the ground, help people in the village, help people in the hospital, help people in the workplace, and help researchers and policymakers understand what the long-term effective program. So that's at the heart of our work, is good method, so that research can be done very effectively, hopefully get it right first time, and what is produced in research doesn't just go into journals, which goes on a dusty bookshelf somewhere, or just stays on the web, but the research generates really useful, practical things that can be used on a daily basis. Our mission, what we really want to have achieved, is not to have health literacy as a project and not to have health literacy as a program, but to have health literacy as normal practice. The recognition and use of health literacy approaches to be incorporated, to be used in a daily basis for practitioners in their daily work, for policymakers in their policy development, and managers in their organisation of health services. So with that introduction and all this talk about health literacy, I guess a lot of you aren't sure what the term health literacy is. So we will talk about that in detail as we go through here. This seminar will work best if we have lots of questions from you. As I said, we're not Indonesian, and yet we want to talk about Indonesia, but we can't really talk about Indonesia. We would love to respond to your questions and your interest about how can these methods and ideas be useful for you here. So will everyone promise me that you'll ask lots of questions? Okay. And very happy for you to ask questions in Indonesian, and then someone can translate. So it's your time here to get good. It's your time to get good. I've been asked to put the microphone up closer. Is that better? Okay. So today is a lot about questions. The main plan is for you to ask questions. We'll talk about why we are discussing health literacy, we'll talk about what it is. We'll talk about a lot of the theory, which may or may not be useful, but what we hope is really useful is the practice. We'll talk about how we can measure health literacy. We'll introduce the health literacy questionnaires, one for Western cultures or high-income countries, one for communal cultures or lower middle-income countries. We'll talk about how might health literacy help you in your work, and what can we do to use health literacy to improve health outcomes and reduce health inequality. And for this to be a successful seminar, we'll need you to ask these questions and help us answer them during this morning. I'd like to introduce Roy Batterham, sitting next to me. I won't give him much of a chance to talk for a little while yet, but Roy and I have worked for about 20 years together, and both would call ourselves methodologists. Roy lives and works in Thailand for the last 3 years, where he has tremendous experience at the village level, at the health service level, and doing right down to ethnography kind of work, really being with families and individual practitioners in many different communities in Thailand. So he'll bring a lot of experience of actually working in the field, and together we've developed a whole range of questionnaires and tools and processes, and now and again he'll take the microphone from me and correct me, and then I'll take the microphone from him and try to correct him. Good. So today is about to have fun, ask really good questions, and to really get down to the bottom of, is health literacy a good thing for Indonesia? If so, how can we use it to make a difference? So health literacy is important. It's in many policies now. It's part of World Health Organization documents. There's even a solid document from Europe. And there's a document being produced by the Southeast Asia Regional Office, the WHO, out of New Delhi, called Health Literacy Toolkit for Low and Middle Income Countries, and that's currently in draft form. And this is something the WHO has commissioned us to develop in partnership with a range of groups to help identify and guide health literacy programs in Southeast Asia and Asia more broadly. The European Commission has white papers and other documents. OECD have an agenda that includes health literacy. In Australia, a range of health literacy policies, from national policies around with the Commission quality and safety of healthcare to improve hospitals, and there's also the Victorian Health Priorities Framework, a very specific priority policy which is designed to support local healthcare organisations through to hospitals. And the USA is the Agency for Healthcare Research and Quality and the Institute of Medicine. They have something called the Health Literacy Universal Proportions Toolkit, a way of auditing organisations. So health literacy is in many places. In Scotland, this policy was first released just over a month ago, making it easy. A health literacy action plan for Scotland, a really interesting, useful document and website available. The Solid Facts book of Europe, a large number of us contributed to producing this document to help guide modern approaches and using the European approach to think about what are the differences between countries with health literacy and provide many other guidances for the region. And this is from the USA, from the CDC. Improving health literacy for older adults is a policy program there. There's many more to go through them. This is from Australia, more grounded policy to support healthcare professionals and managers on the ground to improve services, and this includes health literacy. This policy came out about 2 or 3 years ago, and what they were recommending that there should be a straightforward and useful tool to measure health literacy and guide programs. And that's what we've produced in this time and will present to you today. So we have a big issue here around health literacy, and that patients or citizens and professionals can see the world very differently. professionals have all this expertise, all this wonderful theory, but from people in the community, they have their daily lives. And they may not have many of the same conceptualizations or the same theories or the same views in the world. This is some work done by Rima Rudd from Boston. Consider a variety of health activities or behaviours related to where and why people take health-related actions. So where and why. So with the experts, what do they say? Well, about health promotion, they say that, well, it's about individual action to care for your own health and getting healthy habits. In the health promotion sector, it's about that people should learn things about what can harm them. In the area of disease prevention, it's about early detection and or eliminating risks, getting yourself organised to do that, and getting yourself vaccinated. In the area of healthcare and maintenance, it's about monitoring illness and complying with instructions. And there's systems navigation. This is what is organised out there. This is what should be done and happen at the patient level. Does this make sense? Is that familiar? You're all professionals. This is what most of you do on a daily basis. But the citizens' world, the patient world, can be really quite different. What people in a community say about why they take health-related actions. Well, from their perspective, the way they're thinking and acting on the day, it's really about, well, fear of disease or death. They're acting from that and not some fancy theory or program that's in place. They just want to feel good. They just want to have energy for daily tasks. They want to look good. They want to have their pain relieved and the symptoms gone. They want to prevent the disease coming back. Others influence, being told to do it by your wife or your children, something like that. Sometimes they do activities because they're just pleasing their doctors and other healthcare professionals. Or they want to protect their future function. Or there's family and community traditions. That's why they do things. Not related to any fancy things that our hospitals want us to do or our doctors want us to do. And there's legal and fun things that they want to do. Roy would like a comment.
I just want to ask a question. If everyone in the room can follow the English language well enough, or if we need to have someone summarise every so often what has been said, is everyone able to follow the language okay with the help of the slides?
That's a relief.
Sometimes in Thailand we need, depends on the people who are in the audience, sometimes we need to get someone to summarise to help you together.
Okay, this is another important principle of the way we work. We don't want you to be polite. So if you sit there and being polite, that's not very helpful for you, and it's not very helpful for us. We're here today, a lot of time and expense to come, to make a difference. And if you want to challenge, you need to challenge us every step, please. The university and your organisation is investing a lot of money in you being here. Your time is money. And you're not doing other important things. So make this as important, as useful as possible for you. This is a principle of how we like to work everywhere, that you get the most out of what we have to offer, and you go home with useful things that you can use in practice. So, you agree not to be polite? Good. Thank you.
Say, understand.
Yeah.
To make a comment on this slide, one of the most common mistakes that we find that health professionals make is to think that their patients think about things in the same way that they do. So very often health professionals and policymakers, we talk about things in one way all of the time, and so we think that our patients think the same way as on the left-hand side of this slide, and we often don't make enough effort to understand that the patients have all sorts of very different reasons and ways of thinking about things that are more like the things that are on the right-hand side. And that's a very common mistake. And it's our responsibility as health planners, health academics, health service providers, to put ourselves into the minds of the people that we're trying to work with. And a large part of health literacy is about that. It's about trying to put ourselves in a very deep way and a very day-to-day way into the minds of the people that we work with.
So the differences between these two sides, the slides of this on this slide here, the differences there is it's giving you a sense of what health literacy might be. Health literacy is a very strange term in most cultures, in most languages. Maybe there's a much better term that you can develop in Indonesian which actually captures the idea. But let me now give you some of the common definitions of health literacy. Here's 5 of them. I'll read out one of the first 2. Health literacy definitions. An individual's overall capacity to obtain, process and understand basic health information and services needed to make appropriate health decisions. That's from the US Institute of Medicine. The next one in blue, that's the one that we use generally. Health literacy represents the cognitive and social skills which determine the motivation and ability of individuals to gain access to, understand and use information in ways which promote and maintain good health. That's the WHO definition. I won't read on, but they all have something about understanding, accessing and using health information and health services. So by now, after reading through these, hopefully health literacy is really clear for you. But maybe not. Maybe you're just being polite. So there are 2 ways, there's many ways to come to understand what health literacy is. We can read these academic definitions, or we could look at how health literacy is being operationalized or put into practice. Let's look at the questionnaires now, the tests and tools that have been used to assess health literacy, and then hopefully you'll get a clearer sense of what it might be. So that's the definitions. They only help you a little bit in understanding. How's it been measured? Well, mostly health literacy in the past has been measured through reading ability, comprehension, and word recognition tests. So reading ability and comprehension and word recognition tests. Also numeracy tests as well. A lot of the tools, most of the world's literature has used the Rapid Estimate of Adult Learning in Medicine, the REALM, the Test of Functional Health Literacy in Adults, the TOFHLA, and something called the Newest Vital Sign, the NVS. There's been other tests as well, audits of written materials and health facilities. For example, signage. So a person might come to a hospital, they cannot find where to get their kidneys treated because they didn't realise the sign saying nephrology was where they were meant to go. There's a whole lot of written information and how organisations are organised that can stop people having a chance of getting the health care they need. A lot of that work has been done by a great researcher, Rima Rudd, in the US. There's new and modern scales too. We'll talk about the health literacy questionnaires developed separately in Australia and in Thailand. Also, there's the European Health Literacy Survey. We had an opportunity to contribute to the development of that too. That's used in comparing countries or nations, their health literacy. And there's quite a lot of new ones which we can't go through today. But let me show you these early tests of health literacy so you get to see them in some detail. Now this is the Rapid Estimate of Adult Learning in Medicine. It consists of 3 lists of words, and a person is asked to read them out and pronounce them correctly. If they can read them and pronounce them correctly, they get a point towards their health literacy. They don't need to know what the words mean, but if they pronounce them, then they'll get a point towards their health literacy. Oh, we'll just get a microphone to you.
Is it okay to interrupt?
You're invited to interrupt.
Okay, thank you. So what about if it is, this one is in English, and maybe in the Thailand it's also using the Thai or Indonesian can make it this kind of literacy?
It's possible, but one of the issues is that in some languages there's only one way to pronounce words, and if anyone can read at all, they'll actually pronounce it correctly. So this tool has not been found to be especially useful in the area of health literacy, because people could pronounce the words but then have no idea what they mean, and not a strong link to health behaviour.
But what about the community in Indonesia which is not well known and cannot be speaking English?
Yeah, it would need to be translated to other languages. It had been translated to Spanish, but in some parts of Spanish there's only one way to pronounce things, and so the test didn't work so well. So we don't recommend this tool.
We don't recommend this tool at all in English or any other language.
So the next one is really quite interesting. So here is a medication label. This is part of the TOFHLA, the Test of Functional Health Literacy in Adults. You can see here a patient is asked about a particular, to read a label. Then they're asked a question: if you take your first tablet at 7 a.m., when should you take the next one? And they need to fill in the answer. So if they can read and work out numbers, they'll have a chance of getting this correct. Also part of the TOFHLA are statements like this: reading comprehension. Your doctor has sent you to have a something X-ray. It's a test like in school, a modified closed procedure, where the person has to select one of these options. So this is quite a good test of reading and numeracy related to health. Okay. Question. Can we have a runner for a microphone, please?
Sorry, I'm just wondering, when is the right time to give test to the patient? Because sometimes maybe the patient can answer the question correctly because he or she has been told previously by previous doctors about the instruction of the medicine that he or he should take. What's the right time? How do you make sure that you're
Roy, do you want to answer that one?
In that this is the literacy is about communication. This is a part of this maybe. But about how to make a community or maybe other person level of health literacy, that means if there is something that influences, maybe for example the education level. When you study that in adult, when all that and uneducation, maybe the same question will be different in answer that. How we can get kind of this kind of education to make sure
They're two very good questions, and there's a lot involved in the answers. The first question asks, I think you were talking about if you're a health professional or a health service provider, what is a good time to use this with your patients? The first thing to be said is health literacy tools for most of the past 20 years haven't been used in that way. They've mostly been used for research or for studying the needs of people in an area, or studying all of the diabetics in a province, for example. So they haven't been used to help a doctor or a nurse to understand the needs of their patients. And so there's not a lot of sort of models for how to do that. But just recently, people have tried to come up with much shorter versions, and Richard's going to talk about one of them in a minute, that can be included into the clinical consultation. And our view is that the appropriate time, if you're going to use one of those tools, is if you have concerns that the patient can't understand. You don't need to use it for everybody, but if you have someone, maybe they've come to see you 3 times and their outcomes are not improving and they're continuing to have problems, then you may want to look in more detail and to use one of these tools to help you understand that particular person. The other way you can use it is to use it just with a number of people within your health service to help you understand what are some of the common problems that my patients have, and then to think with your staff about good ways to deal with those problems. And later on we'll be talking a lot more about some specific techniques that we have to help a health service to use these tools, or not these tools, but to use health literacy tools to understand what are the common problems for our patients in our organisation, and how can we plan our services better to meet those needs. So that's a sort of short answer. But health literacy measurement is only very recently people have tried to use it to help care for one patient at a time. Before that, it was all big numbers of patients and planning. The other question was about can people who can't read, or have very low education, complete it? And it's a complicated question. I think it's like there's a level. Okay? So below a certain level, people just can't understand the questionnaire at all, especially the TOFHLA. Our questionnaires can be delivered they don't need to be able to read, because one of the principles for our questionnaires was we don't want to say that people who cannot read at all have zero health literacy. That doesn't make sense to us, because they still know things about health and they can still talk to people about health and so on. So our tools are designed for people whether they can read or not. But still, education is one of the things that feeds into health literacy. So if people have higher education, yes, they do have higher health literacy usually. And it's not just because they can read and write and do sums now, but they understand things like body systems and about germs and about circulation, and so they can understand when people try to give explanations about health, when doctors try to explain about health, they can understand better if they have done a little bit of biology and understand a few things about the human body, for example.
As we go through the presentation, a lot of our thinking will be around clinical care, clinical services, but also equally about health promotion and messages and how to understand the whole population. So keep thinking and asking questions about that whole spectrum. Okay. So a lot of the early tests came from wanting to understand the health literacy of a person in the clinic or across the population, as Roy mentioned. The next one, the newest vital sign, this is an ice cream label. So a person is given the ice cream label, and questions read to them. This information is on the back of a container of a pint of ice cream. The question is, if you eat the entire container, how many calories will you eat? Everyone got the answer? I can never work these things out myself at all. In fact, some of the people, well, the answer is 1,000. But it's not uncommon for people to give an answer like, I don't eat ice cream, which kind of means they have high or low health literacy. It's hard to judge. Maybe high. Okay, so this is one of the tests out there as well. We decided we wanted to use all these tests in a population-based study in Australia to understand them and to see what the health literacy level in Australia was. What happened when we administered the realm, the TOFHLA and the NDS? We found that for the realm, there was about 13% of people who were classified as having low or inadequate health literacy. With the TOFHLA, it was about 7%, so quite a lot less. And then with the NDS, 26% of people were classified as having low or inadequate health literacy. That's a big range, isn't it? So it's a bit hard to judge what might really be the health literacy. Then there was a national survey of health-related literacy, which is often used in the US and in Canada, Australia, a couple of other places. It suggested that 40% of people in Australia had inadequate health literacy. That's a bigger difference again. Does anyone know what happens when you go and sit down with a policymaker or a manager and you say you'd like to do some research or you want to develop some policy around health literacy, and it ranges between 60% and 7%? Do you know what people say to you, the policymakers and managers say to you? They say, there's the door, go through it, out of here, come back when you know what you're talking about. And that's fair enough, isn't it? In 2004, the Institute of Medicine did a summary of the health literacy measures that are out there. As part of the summary here, there are indicators, they are indicators of reading skills, or word recognition, or reading comprehension and numeracy, rather than measuring the full range of skills needed for health literacy, including cultural and conceptual knowledge, listening, speaking, numeracy, writing, and reading. So I strongly recognised that there was gaps in the measurement of health literacy, and indeed they weren't perhaps measuring a lot of those early definitions. We undertook a study of the critical appraisal of health literacy measures that we could find. We published this not very long ago, and we found that, well, a lot of the tests of health literacy failed fundamental measurement criteria. In fact, they weren't really measuring the things that they said they were measuring if you used the common definitions of health literacy. We were very keen to work in the area of health literacy because our work in health education, implementing programs for self-management, working with health services, trying to improve health equity, the health literacy tools weren't going to help us. So we had to think of something else. But despite these weak measures, or these measures that are quite strong in what they do measure, they're measuring quite strongly reading ability and numeracy, there's a lot of research, many studies showing that low health literacy is linked to inadequate knowledge about health in the healthcare system. It is linked to increased hospitalisation, poor access and utilisation of health services, and people with low health literacy are up to 3 times more likely to experience poor health events. Based on these blunt measures, which basically measure reading ability and numeracy and word recognition. So in thinking about all the different elements of health literacy, well, for a person who has got the basics, that they don't have any catastrophic health problems, the absence of poverty and safety, they have food, they've got a roof over their head, then they can we can work with them in a constructive way. But a person, first of all, needs to have language. They need to be able to communicate in some way with healthcare professionals. They need the vocabulary. They need to know what the words mean. They need to know the context and how these words and the ideas about health can be used. Then they need another range of competencies, skills and abilities, and reading and numeracy. But still they need some sort of empowerment or agency. So that it's okay to talk to a doctor. It's okay for them to have a good health. That it's okay for them to try hard to overcome their diabetes and use medicines and use family money to get well. And it's okay for them to do that. Around the individual, there's all these other supportive and determining structures about their faith and their trust in the healthcare system, about their mental health and emotional status, about cultural beliefs, and about environmental factors around them. So it's not just enough to be able to read and write, understand health information. More things are involved in enabling a person to have a chance of having good health. Are there any questions? Microphone, please.
Sorry. This is very interesting term because this is the first time I have just exposed to this new term. As a doctor, I met a lot of patients who do not understand about our medical instruction, but I think before we go to the health literacy, I think what we really need is that the health awareness from the patients, because if many of my patients, I cannot expect them to be literate, health literate, because sometimes they don't know that they need medical help, or they don't know that they are sick and need medication. And that's why I think before you go to the health literacy, maybe, yeah, how do you make sure that the patients are aware about their health problems?
That's a fantastic question, and that's really at the heart of why we don't use those tools that Richard's talked about anymore, and Richard's about to talk about some modern tools. Because, as you say, there are many other more basic levels of understanding that the patients need to have before you worry just about reading and writing. And sometimes, in many societies, reading and writing isn't the most important thing anyway. They're conversations that they have about their health with their family members, and many other issues that are the most important thing. One, health literacy, as Richard said, is quite confusing, and often it steers you to think just about reading, when we want you to think much more broadly about all of the cognitive abilities and the social abilities that allow people to understand their health and to have good discussions with their doctors and their family and so on about health. And so to help you understand the idea about health literacy a little bit better, it's actually not a new concept. It's quite old. It comes from 1974. And at the same time, people came up with concepts like financial literacy. Financial literacy isn't just knowing how to do numbers and things. It's understanding all of the concepts about loaning and debt and all of those things. And people also talk about computer literacy. It doesn't mean knowing how to read about computers or write about computers. It really means knowing how to use computers when you talk about computer literacy. And health literacy is really the same. It's more like that. More like thinking about computer literacy or financial literacy. About everything that you need to be able to think and understand and to do the tasks that you want to do effectively. And then we'll talk about some of the other tools, maybe cover some of those other more basic issues as well as just reading and writing, some of the things that you are highlighting and that we want to highlight also.
So we're worried about you, the doctor, and we're worried about the health promotion officers. We're also worried about the managers in businesses trying to keep their workers healthy and safe. We're worried about hospital managers managing their budgets and not having too many people coming back with avoidable disease. And we're really particularly worried about how can those people who can't read and who are disadvantaged can have a chance for good health too. So this creates a headache to be worried about so many things. So we've seen those questionnaires before. Has anyone developed a questionnaire before? Okay, a couple of people have. Did you enjoy it? And are you happy with the result? Yeah. It's fun to do, but there's a bit of a problem. If you do a really good questionnaire, that's great. It gets used by lots of people, and it helps a lot. But if you do a bad questionnaire and publish it, it follows you for the rest of your career. So it's risky to do a questionnaire, and so it's important to get it really right. And we've developed a lot of questionnaires before that are used in many parts of the world for different conditions. So we need to develop a new questionnaire for health literacy, but we need a method that we can really, truly get the patient's perspective or the citizen's perspective. But there's no good just having a perspective, well, it's good to get the perspective of the patient, but how is the tool going to be used to change the system, to change practice, to support managers to do a better job, to enable patients to have it, or citizens to have a chance of good health? So we need to include both groups in our consultations. Part of our work also is very careful to be very clear about what we're planning to do in developing a questionnaire, because that's one of the first most important parts of questionnaire development. And there's many steps, and I can't go through them all in detail. We could run a very separate workshop about that for a whole week, probably. But the issue about developing questionnaires, if you get this first step wrong, the purpose of conceptualization, everything else will be wrong. So you've got to get the thinking right at the start. That's all I want to mention about that. But we've been thinking about health literacy for 8 years before getting to where we are now. We'd like to use a particular process called concept mapping to get to the heart of the consumer, the heart of the citizen, the villager, in their daily life, or the practitioner, the manager in the workplace. So concept mapping is a structured conceptualization process that captures the local wisdom or the local knowledge of the patients, practitioners, and the policymakers. So all these people we talk to. We develop a questionnaire by talking to people. Most questionnaires in academia in the past have been created by, I'm a professor or I'm a budding academic, I have a good idea, I have my theory, I'll develop a questionnaire to measure my theory. And it's not always that the questionnaire is developed on something strongly linked to the real world and is risk but not being useful. There are many great clinical questionnaires and tests that work beautifully, so it doesn't, but again, it's generally a grounded approach. As part of this process of concept mapping workshops, and Roy could be easily described as the world leader, the most experienced person in this, having done hundreds of them in many questionnaires. I'm a bit nervous about talking about that with him sitting next to me. But we always spend some weeks making sure we ask the right question in the first place. So we're seeking to measure health literacy. We're seeking to really measure something at the heart of individuals' lives, such that we can understand how to enable them to understand their needs and be able to understand access and engage in healthcare. So we ask this very general question. Thinking about your experiences in trying to look after your health or the health of your family, what abilities does a person need to have to be able to get and use all the information they need? It's a very general statement. And we ask people to think about this quietly by themselves for 5 minutes and write them down quietly. And then we do a normal group technique process. We ask one by one to go around the room for people to raise what they think, the first idea in their list. And so we work with ordinary people in the village, or ordinary policymakers, ordinary academics, although academics are special. But we mainly work very carefully with the community, but we get everyone's perspective. Many steps also go after this, but I want to make this key point, that our work is using grounded approaches, that we start in the hearts and minds of people in the community. We get their voice to guide us, then afterwards we see where does this fit with theory. Because number one, we want to produce a product, a process that's useful for people on a daily basis. And this is what we come up with. This is what we call the Health Literacy Questionnaire. I'm going to read through each of these dimensions with you. There's 9 separate dimensions which came out of this consultation. They're all separate ideas. Statistically, we've found that they are covering quite different parts of the person's thinking in their life. They respond differently to each of these. There's 9 of them.
Just in case you're not sort of familiar with the way questionnaires work, these have got 9 sort of concepts, and each of these questions has 4 questions related to it. Okay, there's one example question written up on the board here, but usually there's 4 questions, and between those 4 questions they cover the important issues related to that concept, and they also help correct each other's errors in the questions to make the score that you get more reliable and trustworthy. So the tool is about 46 items, I think, covering these 9 domains. On one scale, or one of these concepts, is usually a set of 4 statements like this that people are asked to give a rating on.
So as I read through these, sit back quietly in your chair and think about patients, how they respond, but also think how it reflects me as a practitioner or a health promotion officer or as a manager. Because each of these statements, each of these dimensions are reflecting 2 things. It's the patient's world, it's the world around them. So the first one is feeling understood and supported by healthcare providers. An example question is, I can rely on at least one healthcare provider. It tells you information about the patient's world, but also about the environment in which they're working, they're living. The next one, having sufficient information to manage my health. I am sure I have all the information I need to manage my health effectively. It's a pretty tough question, isn't it? We're saying, I'm sure. Am I sure? Think about that. And manage my health effectively. Wow, I'm sure health effectively. That's a really hard item to answer. At all. Yeah. All the information. So really challenging people to think very carefully. Do they have really everything? Are they sure they have everything that they need to manage their health? So this tells you again about the patient world and the environment they're in. Number 3, actively managing my health. Example question, I spend quite a lot of time actively managing my health. Very much around the person, isn't it? But then there might be environments which are really hard to actively manage their health. Their village or their environment, their daily life, their workplace, how busy they are, they may not be able to. So it also reflects their environment. Social support for health. I have at least one person who can come with me to medical appointments. Number 5, appraisal of health information. When I see new information about health, I check up on whether it's true or not. The first scale is about agree or disagree. The next scale is cannot do or very easy, so it reads a little bit differently. The first scale, ability to actively engage with healthcare providers. Discuss things with the healthcare providers until you understand all you need to. So this is also very much about the patient's ability, but also how engaging, how approachable, how receptive is the healthcare professional. A reflection of that too, isn't it? Number 7, navigating the healthcare system. How easy or hard is it for you to work out what is the best care for you, or decide which health provider you need to see? Tough questions. Number 8, ability to find good health information. How easy or hard is it for you to get information in words you understand, or find information about health problems? And number 9, understand health information well enough to know what to do. How easy or hard is it for you to read and understand all the information on medication labels? Or how easy or hard is it for you to understand what healthcare providers are asking you to do. So this is very different than what we've seen before in health literacy questionnaires. It's designed to be administered orally or by paper. Any reflections, any comments or questions about what you see in these ideas on the board, on the screen? Can we have a microphone there, please?
Okay, thank you. According to question number 2, number 4, and number 8, I have interesting about if the community believes the traditional medicine, it is, I can say, there in health literacy. Because in Indonesia, many people most like traditional medicine than medicine professional.
Great. We might take a few questions like that, but any more questions? Over here, please. Thank you. There might be a few questions together we might answer together. That's all in this particular
I'd
case.
like to come back to definition when we see in your beginning of presentation. I just still not clear, but I would like to question about that. When we talk about health literacy, and you have already said that this is about a broad spectrum about health literacy, we have to think about that. Is it right when community, patient, and then policymakers, and also journalists, like journalists, have to some enough level of health literacy. So then, when we come to the health policy in our country to develop our public health in our country, Indonesia, so we have to, I think, like in health department in nation level, we have to know about level of health literacy with the different kind of community like this. How far journalists have to know about health literacy, should in enough level they should reach about this, and maybe the different health literacy it happen when we say I'm a patient, he is a health professional, is a doctor, but health literacy should be like I have know about that, and the others have know about health literacy. I think how we can make explain so general what health literacy is when we see many kind of community or many kind of institution in our country has to got this kind of level of this health literacy. So in our nation we come together, move together when we try to develop our health system. You know that we still have poverty, education problem, but this is around us. But how we can make all people in Indonesia have the same mind, okay? And then we have the same conclusion, and then we can go together. That is our problem. It is still not easy for that. Even we just want to promote about national health, for example, but when we talk about health literacy, it's something more the big message. We have to stay on that level so we can go on with my health level. Do you understand what this is like so complex for us, for me especially, to understand the health literacy, but the explain is about health problem and how we can move from the health literacy issues to the health development until we have a good quality in health.
Yeah, we will certainly. That's a very big question, and that's at the heart of what we want to get to. So we'll build a full answer to your question in the coming part of the talk. you want to make us? I don't like it when people say that to me. That wait, we'll tell you later. But do you want to make a comment?
Yes, I do.
Sure,
of course. We have already heard from two people in this room about the range of perspectives that people can think about health literacy. From one doctor thinking about how to manage, to thinking about policymakers, and our colleague over here asked a question to, is it possible for people still to have health literacy that looks like it's high, but really they're trusting in traditional medicine and not trusting in modern medicine? Okay. Our view is that there is a problem. People are not going to be all thinking the same across all of those levels you talked about. If the doctor's always trying to understand what is happening with my patient, or the community nurses are trying to think about the patient level and the patient world, and people in policymakers just think about statistics and numbers. Okay? The big gap between policymakers and health providers is that policymakers don't understand the stories underneath those numbers. And so a lot of what we're trying to do all of the time is to bring the stories up from the ground level to each level above that. And so that when a policymaker looks at the statistics, they can actually think that this means people in the Indonesian community are having these troubles and difficulties in making decisions. So that's our general approach, is in some ways to play favourites with the people who are on the ground, because we see that as a big weakness that policymakers need to have a similar understanding of what the numbers mean to what the people on the ground do. In relation to the other question, the scales in the health literacy questionnaire operate separately to each other. So yes, some people can have high scores on some scales because they have a lot of trust in traditional medicine and relate well to their traditional medicine provider, but they won't score highly on all of the scales. And so that's part of the approach, is to say that some areas are strong for these people and some areas are still problematic.
Thank you for those questions. Great questions. So the presentation at this stage, I presented the health literacy tool, which we're very proud of. So the key message is here that's telling us two things. It's giving us insight into the needs of a person, but also the needs of the organisation. So it tells us about the patient, and it tells us about the organisation's responsiveness or capability to understand and support the community. And very proudly, it's been published in quite a prestigious journal, BMC Public Health, open access, been downloaded 14,000 times, been tweeted to 200,000 accounts. So it's even more, but anyway, a lot in a year. So there's been huge interest and demand in this. So we're very proud of that, and there's 150 groups around the world using it, so that's exciting. But for Indonesia, this is not good enough. In part because of our question here. What about traditional medicine? Because that's daily life here. So we should never assume that a tool from one culture is suitable in another. So we did this entire process again, but even better. So this is in developing a health literacy questionnaire for communal cultures or low and middle income countries, which is based in Thailand. So it's very hard for either myself or Roy to speak briefly about something. So I'm going to get Roy to talk to you about why we've developed a tool very separately from the English tool or the Australian tool, and take you through what it looks like.
some of you probably know that from your experience that a lot of times tools and even theoretical models and so on that are developed in America or Australia or England or Europe, they're often quite individualistic and focus just on what's going on inside one person's mind and one person's decision making. And we were very concerned with health literacy that it needed to be appropriate in cultural decision makings where all the decisions made about health are not just made by the person, but are made sometimes by their family or by sharing with their family members or their peer groups, the other women in the village. That a lot of decision making in health is not necessarily made by the individual, and so we're interested in having a tool that will enable us to better understand how health is made in those sorts of settings. We also were aware that in some cultures there's not just one paradigm for thinking about health, the modern medicine paradigm. Even in Australia, there's not. And that in many countries it's not a matter for people to choose between modern medicine and traditional medicine and religious sort of advice about health and the advice that comes from their grandmother about health issues, but usually people try and combine them together in a way that makes sense to them, or they will try something, and if it makes them feel better, then they'll keep doing it, and if it doesn't, they'll say that it doesn't work. So we have to think about the process that people try and make decisions and combine that advice. And so that's why we wanted to go through the whole process again and ask people in Thailand this time, in very sort of remote villages in many cases, what are the things that are important for you in making good decisions for your health personally and when you need to look after your parents or your children or other people in your community.
So this is what we come up with, and again, Roy, you're most welcome to. We've just finished this and been partly translated to Indonesian already.
So with the title, we ended up with some similar scales to the English scales, which we've called the core scales, but they were also very interested in issues about people need to make good decisions about very specific issues like food and exercise and so on. So it has some content scales as well. The core abilities relate to people's ability to access health services, which is the same as the Australian one. Ability to get information and advice you want from a healthcare professional. And with this one, there was a lot more emphasis on having the courage to be able to ask questions, more than the Australian tool, because many people, they didn't have the courage, or because of cultural issues, they don't want to appear disrespectful to the doctor, and so that the content of the particular questions was different in Thailand than in Australia, even though the issue was the same because of the culture. The ability to find suitable health information, evaluating which information you should trust and how you can compare, whether the close people around you were very supportive to you in your health and your family or friends look after each other's health, taking responsibility for your own health. So there's a similar item in the Australian scale, but that relates to also how important is health to you as an issue compared to work and worrying about your children's education and thinking about your parents' health rather than worrying about your own health and many other issues. Knowing what you can get. In developing countries, often the health programs and health services are changing all of the time because people come up with new programs. And especially when we did this consultation with people with disabilities, and a lot of disability services in Thailand are very new for blind people and deaf people and people with physical disability. And it's very hard for these people to learn about all of the things that they can get. Similarly, trying to introduce universal coverage healthcare. What are the rules for universal coverage, and what can I expect to get when I go to my hospital, and why do my friends who go to a hospital in a more major town say they can get so much better things than what I can get locally, and so on. And then what is available in my community, in my village, to help me support. We also did this consultation, the concept mapping groups, for the first time in the world with people with physical disabilities, people who are blind, and people who are deaf. Because obviously blind people and deaf people have some extra challenges for health literacy. And so we asked them about their needs as well, and that also some of them went into some special scales for those people, but some of those questions went into the general scales as well, because not everybody in the community sees very well. It's not just blind people who have problems with their vision, and not everybody can move around very easily. It's not just people in a wheelchair who have difficulty with moving around. So some of the questions from those groups also came into the main Thai health literacy questionnaire. And so, but there are some extra scales that are just for the deaf and the blind and the physically disabled group. The other thing that we did, which is a world first, is that all of the questions are available in sign language on a DVD. So we can actually administer the questionnaire on paper, or by reading in an interview, or with sign language, and we know that it gives more or less the same answers. No one's ever done that anywhere with a questionnaire before.
Oh, some questions. Great.
Thank you. We have do some survey in Semarang City with Europe questionnaire, health literacy questionnaire from Europe with ASEAN Health Literacy Association, and we have done with more than 1,000 people in Semarang City, and it as a project for health literacy study in Indonesia, maybe. My question is, we have do a translation. We have done a translation from English to Indonesia, and we collaborated with ASEAN Health Literacy Association. And I think I have a question. There are many questionnaires from Europe or from you from Australia, and you make it for Thai people. So, is it important to Indonesia people to make questionnaire, or just adopted from Europe or Australia or Thai?
Great question. Yes, a very important question. What's important is that if you use the same questionnaire across countries, then you use the same questionnaire. So if you want to compare with what's happening in Taiwan, which is where the ASEAN, I'm linked to that network, and several other countries, you can compare at a national level, so you use the same questionnaire. And same with our Australian questionnaire, 30 or more universities around the world are going to administer to their health science students to look across the world, what's the health literacy of science, of health, the doctors, nurses, other healthcare professionals, to help develop them. And we have a colleague here is part of that project. Dr. Rita, what was the name of our colleague from? It's you! Ah, yes, of course. Hello! We're communicated by email and I should have asked people to introduce themselves when the first, yeah. So in that setting, you'd like to compare to see what differences are, because that gives you different insights. With we decided that we needed to develop something for Thailand with the Thai Ministry for Health, so that we could really deeply understand and improve the systems appropriately, culturally appropriately in that country. So it was seen as a priority, and there was a lot of thinking that the Australian tool wasn't strong enough to do it properly. But sometimes a tool is universal across cultures, sometimes, and you need to test that. Some of our other questionnaires have been translated to 30 different languages, from African, Asian, Eastern European, Southern European, and it's but it's very clinical. And so people are consistent in the way they think and respond all around the world. So I haven't yet answered your question, whether we should develop one from the start for Indonesia. We kind of hope not, because it's such hard work and it takes such a long period of time. And when we developed the tool in Thailand, we kept thinking about not just Thailand, but about people in the village setting in Asia, and we were really hoping it could be suitable for other cultures as well. So the work with Dr. Rita, we will be administering it and testing it and validating it for Indonesian people across different settings. So we need to prove it's good for Indonesia. And there's two ways to do that. There's many ways. If the questions and the ideas make sense to you guys. So if once Roy presented these ideas, you all had your hands up saying, that's silly, it doesn't make any sense to me, that doesn't fit here. So already we're getting information that the ideas are appropriate, that the Thai tool is good for, potentially good for Indonesia. But strong testing at the practitioner level, policymaker level, and at the community level will be finding out how strong it is to inform services here. So hopefully not, because it's expensive and exhausting, and I think there's only a certain number of questionnaires that anyone should make in the world, or they get too grey and lose their hair.
We're very much hoping that the Thai tool will apply to countries where these sorts of characteristics apply. So where a lot of health decision making is not made just by individuals, but is made in family and sort of communal contexts. Where there is that issue that we talked about needing to reconcile modern approaches to medicine and traditional approaches, where health systems are in evolution and tend to be changing quite fast because they're continuing to develop, and there's a need for people to keep track. And also in many countries in Asia, there is a tradition of having lay health workers, village health workers, who are really health literacy workers in a way, and where their role needs to be considered in anything to do with health literacy policy. So we're hoping that the Thai tool will be appropriate in sort of all of those cultures where those range of conditions apply.
Okay, that's a question that we're hoping someone would ask, so thank you very much. Okay, so this is a natural time for us to have a break. Is a break acceptable in Indonesia, or shall we keep going? We try to be very sensitive to local cultures. I once gave a presentation in New Zealand with Maori leaders. Maori people are very strong people, and they're very keen to do things correctly. So I was always asking permission and what's the right thing to do now. And that helped a lot. So,
yeah, I think we'll have a break for 10 minutes, okay? There's coffee there. And then after you can have a small snack there, just come in 10 minutes. Is it enough?
Five, maybe 5?
5 minutes.
Okay, see you soon.
Yeah.
at Mr. Roy's. Hello. Nice to meet you. Yeah, thank you for coming over this way. That's very good. Yeah. It's in the village, yeah. Taiwan's very different, very Western. It's the first most Western of the very Asian countries, yeah. Ours is designed for both, that it's for community and for clinic. Specifically, we made a big effort to make sure that it doesn't matter if you're for health promotion or for disease management, it works. So that was a big challenge, and it's certainly the Thai tool is perfect for both too. Very hard to do, but yeah, it's done. Good question. Thank you. Yeah, I do want to get you. Yeah, thanks.
From Andalas University.
Great.
And Andalas University has an MOU with the Deakin University.
Great. So we should work together.
Yeah.
Yeah, great.
So when would you like both of you go to Andalas University?
We'd love to come. We haven't been there yet, but
We can schedule that.
yeah. In the coming months, we could work out. Yeah. So are you? Excellent. So at the end of that, we have a section to think about. Well, what would you like to do in your research? So we'll have a discussion then and build a community of this, and so that'll be very good.
Doctoral degree and master degree, and maybe it's in doctoral degree it could be research.
Perfect. Yes. Perfect. Perfect. Move back in the room. So. Hard.
Kalau masih ada. Yeah.
You have lots of other people's cards, but none of your own.
It's already finished. It's changing all the time.
Ah,
Because we are not a business woman or business.
yeah.
If
Yeah.
it's business,
Yeah, they are. But
I get the bahasa one, but not the
I understand. Bahasa, right?
It is in bahasa.
Bahasa mah buat belajar.
well,
This is in bahasa.
that's okay. That'll help. I need it just a stimulus. Thank you. Yeah. Yes. Okay. Yeah. I'm actually dyslexic. I'm dyslexic, and so I don't remember names or faces, but I can recognise it. Yeah. So that triggers my memory. Yeah. Just move back in. Cool it. You think? It's fun having you here too. Makes my job much easier. Thank you. Makes everything much better to do it together. It's just more fun too. Good questions. They're asking questions. It's going really well. I want to draw in workplace health a little bit. So now we've got to go through the affiliate process. That's where we're up to. This is the challenging part of it. Just so, and we'll refer back to that very insightful lady at the end. I'd like to find her. It's great that they're challenging us. Your answer was right. We're starting? Yeah. Okay. Other people are. There's no signs on the door.
Okay, I think we already have our break for a while, and then let's begin with the seminars again. Hello? Okay.
Just do it. Which one? No. I'll put it onto the desktop. When you want it, I'll just exit out of mine, I guess. I don't know why it's doing it right now. Let me sit down. I don't know why it's doing that. There's something you want to do in particular, is there? Oh, yeah, you can do that now. I'll see if I can open up. Open recent. That's a good distinction. All good.
We all back? I just want to show you a couple of slides in answer to some of the questions that were asked before the break. I'll be showing these slides again this afternoon in the workshop and discussing them a bit more, but I think they're good for helping to answer that question. Also, Richard and I were just saying in the break how excellent the questions were that were coming, some of the best questions we've ever had from a group. And so fantastic questions, and just keep asking them. They're really good. So this is an example of some results from the European Health Literacy Survey. It's not one of our tools, but you can see on this questionnaire that what they're trying to do here is compare across a number of different countries. People their health literacy levels and how many people have really good health literacy compared to how many have quite poor health literacy in different countries. And that's one valid way of using health literacy measurements. By contrast, right at the other end, you can come back to the question that our doctor friend asked early on, and about how can you use health literacy measurements to work with one patient. And so this is a feedback sheet, and we'll be using one similar this afternoon, or using one of our questionnaires, the Australian Health Literacy Questionnaire, to give feedback to a patient and to have a discussion with them about what they find helpful and not helpful in using health information. And so on this questionnaire, it's got the Australian average for each scale marked with a little man and the person's score marked with a little cross, and you can use that to discuss with the patient what their needs are and what their problems are about health literacy. So it's kind of two completely different ends. And so we think about health literacy measurements, this is the question that came just before the break, at a number of different levels. And what's the purpose and role of doing health literacy measurements at different levels, or international comparisons, or national surveys in local areas, in individual health services, in a particular patient group like diabetes patients in an area, or people with disabilities in an area, right down to the individual level patients. Okay? And you can use health literacy measurement for the purposes that are up on this table at all of those different levels. Now we're about to start talking about some specific processes that are really targeted at the middle of this range, targeted mainly for local areas and for health services, for how they can use health literacy measurement for their planning and for quality improvements and to improve the outcomes of the group of people that they are responsible for. That process we call the TOFHLA process, and we're just going to discuss that a bit more now. But I just thought I'd try and give a bit more about the questions we had before and also show where the next bit fits into the whole big picture of measuring health literacy.
Okay, we're very concerned, very interested and worried that if we do something, it's actually useful for the community. So we worked for several years to win a large grant from the Australian government to develop what we have called the TOFHLA, the Optimising Health Literacy Process. And it's with another university, Monash University, and it's in a very big partnership with our government. And part of our approach is to actually co-create working partnerships, a core principle. The co-creation principle here is that 4 years ago I went to see a senior bureaucrat in the government and asked, Janine, we've developed this tool. It's the first version of that tool. We think that there's something in this. What do you think? And Janine said, oh, I think this could be really useful because we hadn't thought about this before. And so we co-developed the research program with our government. So we didn't go in there as an academic group and say, government, give us money because we want to do this research because we think it's important. So we co-developed it. So that's in all our work, whether it's with at the patient level or the practitioner, the organisation, or the central government, it's about how can we work together for good. We have a range of principles that it's important for us to work by. And we'll go through more of this in the workshop. And I just briefly, as you would have already sensed, a lot of these will make sense as I read through them. We seek for our work to be outcomes focused. We want something good and real to come out of this. We seek it to be equity driven. We're doing this really to reach harder and faster and better into people who are disadvantaged, who have less resources. We co-create. We do it in partnership with people, as I mentioned. We do a needs diagnostic approach. We'll explain this a bit more shortly, but we actually seek to find out what are the needs of people. If you want to develop an intervention that's going to make a difference, you should develop it to work on the mechanisms to improve. So what are the needs of people? Driven by local wisdom, and I understand the term, there's a local wisdom is a normal part of the Indonesian language. What's the term? Yeah, I should learn to pronounce that. Next time I come, I promise to pronounce that. And we seek for things to be sustainable, not just a project, but to be embedded, to make normal practice. That it's responsive, that we're not going in there with just academic ideas, but we're going in there to think and feel, smell, hold the hands of people to find out what are their needs and respond to people's needs. And to be systematically applied, right from the micro level, at the citizen level in the community, right through to the policy maker, and all parts of the system considered. So this brings together the last 20 years of research to try to do useful work that becomes normal practice and is effective. One thing is very interesting. So who in the room has studied intervention science? Who in your course, or you've done a degree or a master's in developing interventions? It's very, very rare. In health and public health, medicine, people develop interventions and go and implement them, but they haven't necessarily studied the science, the method of developing interventions. It's really very rare. There's very few fields who do that. So we take a very clear intervention development science approach, but like with questionnaires, if you get the first step wrong, everything else is wrong. If you're developing an intervention which is not meeting the needs of the community, what's going to happen? Not much. We go to a lot of trouble to really understand the needs so that intervention will fit the environment, fit the people, fit the system. With TOFHLA, the optimizing health literacy approach, we're seeking to build a framework. So we're going to try to present this in various ways to you. But we start with local stakeholder. Identify the local priorities. There's no good doing some research or intervention in a business, an organisation, or a health service which is not really of interest to them. But there's no problems with tuberculosis there. Why do a tuberculosis project? So we use universal methods and approaches to solve whatever problem is there locally. Then we document local needs. So the health literacy questionnaire is administered to normal people, the ordinary kind of people coming in every day to your services or are there in their homes in the village. And when I say ordinary, a lot of research is done on those people we can quickly and easily get to measure. We really seek to work with health services to talk to people who have talking difficulties, who don't like to fill in questionnaires, who are very poor, or because we want to have good representation across all the people who are using services or could use services, who may need to use services one day. We do very careful and broad selection of people. Then magic begins to happen. This is where we uncover local wisdom. So the data here from the health literacy questionnaire is processed in a special way and presented back to the frontline practitioners and managers in a very special way, and I'll show you that with some diagrams soon. Then we co-develop a framework, co-develop what is the solution, and develop communities of practice. Ideally we have 5, 6, 7, 8, 9, 10 organisations all working together in the same area, and they share their knowledge. And they become partners. We develop leaders. We support people to have new roles and to develop some things they're proud of, and they can share their wins and share what's not working so well. And that builds strength, and it more rapidly increases knowledge, increases uptake and impact.
Let's make a comment. I just want to make a comment on the very first step there on identifying local priorities. What we mean by that is not just saying diabetes is a priority for our area or something like that. It's thinking about your organisation or your region and what the health priorities are, but specifically asking who aren't we being effective. Health literacy is about problem solving. So if you're being completely effective, you don't need health literacy. Okay? The question is our problem that there's a gap between our diabetes screening, which we're doing well at and getting up to 90%, and the proportion of people who are achieving control who still remains about 40%? Is our problem that we can't engage men in the community, or we can't engage certain tribal groups to come to our services at all because they don't understand about the services or trust them, or they're not presented to them in a way that is meaningful to them? So it's not just about sort of listing diabetes as important, but thinking deeply about whose needs are we not meeting as well as we could. And health literacy is really about finding strategies to solve problems for the people whose needs you're not meeting as well as possible.
So overall, we're seeking to co-create with stakeholders at all levels, patients to policymakers, to ensure local ownership, focus on outcomes and equity, with continuous and systematic response to local context. With this, we seek to do systems change, improve equity, and improve health. So this is the overarching process that we use. Now, there's I just love this part here, uncover local wisdom, because so much magic happens here. When you run these workshops, it's so exciting. But I want to talk about the advantages of working with frontline practitioners and managers. Practitioners can any kind of healthcare professional, really, who works on a daily basis and love the people they're working with and for. They work for them for years. They've seen people born and die, get well, get ill again, to give up smoking and then give it up again and again, and they've been in the community. They understand the local context. They have such deep knowledge. And it's the managers of the practitioners who have been working in this field for a long time. So, the first point here, number one, they have years of experience and tacit knowledge. And they're important resources. They've got really deep knowledge, and sometimes they just don't know what they do. They just do it, and it works, and they keep doing it. They have deep knowledge of the local situation. They have deep knowledge of the people we seek to help. They're able to respond to issues that are not covered in the published research. I usually talk about this a little bit at length, because if we bring something from published in Australia and try to stick it into your village here, it's not going to work, probably, because the Australian towns are so different to your village here. And it goes for the American research, the UK research. So much of the research is not suitable for your context here. So our frontline practitioners and managers understand the local situation, and they can respond and adapt. This is particularly important, number 5. So if your frontline practitioners and managers have developed the intervention, they're probably going to like it. They're probably going to be proud of it. And it's probably going to work. It's probably implementable, rather than bringing some external model in and trying to stick it into the system. You don't need to try to convince people it's a good idea once the innovation is developed. Obviously, it's their idea, and they can be proud of it. So you can see the sort of tricks in here for implementation. They're not tricks, they're just, in many ways, is sort of common sense. It's what really good managers do already to empower and organise systems change. Is there any comments or questions about that? At the end, we're hoping that you don't actually see much new in what we're saying today. It's a funny comment, isn't it? So already your practitioners and managers in the community are doing wonderful things. So with the TOFHLA process, if you've got 8 villages or 8 community health centres, and you have nationally a higher rate of maternal deaths last year than the year before, some at your 10 community health centres, some have a lower rate than national, some have a higher rate than national. So with this process, we can uncover what's really going on in the centres who have doing the best practice. Something going on in these 3 villages or these 3 community health centres where the death rate's lower. Oh, this process gets into the mechanisms by which that might be happening, and it gives the platform a place for your best frontline practitioners and managers to reveal, to say what, to give their local wisdom on the table. That's where the magic is. But it's not magic at all, is it? It's just smart practice. But it's actually setting up a system to ask the right questions, and when those questions are answered, you take that knowledge, you take those data into knowledge, into action. So we're seeking to build a framework. So when you ask detailed questions in response to the health literacy questionnaire, we work at the patient level, the micro level. We build strategies to support, build capacity of individual consumers or patients or community groups. At the practitioner level, we're seeking strategies to support and build capacity at the practitioner and staff level. At the organisation level, we're seeking strategies and to influence the culture and to improve accessibility, efficiency and equity of services. And then regional, state or national level, what strategies to organise service coverage and integration. So there's a whole systems approach. But it starts with deeply understanding the mechanisms at the individual and group level at the bottom here. So this is actually the 9 levels of the health literacy questionnaire. So the TIE tool, which we'll hope to use here for this process, will have a few more finer grain detail, including all those issues around disability and stress and use of local medicines and the normal approaches that people have here, we hope, in Indonesian villages. So when we present these data back to your frontline practitioners about their patients, because it's from their patients, that's a really important point here. It's from their usual patients or community members that they look after every day. So they have respect, ownership, because it's about their patients. It's not some fancy bit of text from an American journal. It's about local data. So at the individual level, there's potentially thousands of strategies that are or can be used by healthcare workers in direct contact with patients or consumers or health workers or workers. These impact one or more of the following areas on the health literacy questionnaire. Now, here's a bit of a tricky thing. So here's all our measures, all the indicators from the health literacy questionnaire. Often, when we present our data or you're reading about data, all you get is like the averages, the means. So we could give you the average on this scale was 3.2, this one was 2.2, 2.4, and if we present that back to practitioners, they'll start yawning, fall asleep, or walk out. So how do you take questionnaire data that gets people excited? So a mechanism that Roy brought to the team was to do a multivariate statistical technique called cluster analysis. Now what's this? I find this hard to explain, but Roy will also have a go, but I'm going to have a go first. So what this is, let's look at the data. What are the subgroups of individuals who are turning up to your health service? So here's a subgroup statistically that all seem to have quite high health literacy. Green is high. Green is good health literacy. Red is low health literacy. So this particular group here, across all the scales of health literacy, basically pretty good. At the bottom here, most of the scales, people have pretty poor or low health literacy. In the middle is a combination. Some people got high levels and low levels of health literacy. So statistically, doing multivariate analysis, you can pull out what are the different subgroups in your society, in your organisation, have different characteristics. Now this is really appealing to practitioners and managers because a lot of you are practitioners and managers already, or will be soon. Yeah. And people are different. You have to deal with different people in different ways. Some people are strong with some characteristics and strong with other characteristics, and weak, and terribly weak at others. So as managers or practitioners, when a person comes in, they sit down, you have to discover what are they like, what are their characteristics, what are their strengths and weaknesses. And it's great to take a strengths-based approach too. What are their strengths? Let's build on them. So effectively, statistically, we can pull out all the different subgroups of the kinds of people turning up to your service. Here we have some demographics. The average age of this subgroup is 54. Here's a group who's 70, and the number of individuals in this particular group. This is actually data from our current study in Melbourne, in Australia. It's more magic. Along here is a health literacy profile, just like I showed you before. This is just one selected out. This person has a low on this scale, very low ability to find good health information. We're not too good at appraising information. They're really good at active engagement, their healthcare provider. So we can turn this into a story, a clinical vignette. So these questionnaire data are turned into a story or a scenario about that patient subgroup. So Mrs. Kinder has been attending the same doctor for 20 years and trusts his advice completely when it comes to looking after her health. She doesn't really see much need to do anything else and doesn't even worry too much about it when the doctor tries to explain about her disease, so long as she follows his instructions. She usually ignores information that doesn't come from her doctor. Her main problem is that she is not always sure how to follow the advice. For example, how she can tell which foods have less salt. She thinks she is doing what she has been told, but isn't always sure. So this is actually a subgroup of people in this community, and this vignette comes from the data, the questionnaire data, but also from qualitative interviews to make sure we get the context. So you could imagine in your health services or the people you're in your businesses or in your hospital, patients coming in, you could administer the questionnaire. You could see what are the different subgroups, people who have all these different troubles, strengths and weaknesses, and then you can build a story and then get your best frontline practitioners to sit around and say, hey, do you see this kind of patient in your organisation? And we've run this 20 or more times, and every time the practitioners say, oh, yeah, and they just start telling us how they solve problems and all the contextual issues of people who look like this. And we get tremendously rich data from ordinary frontline practitioners explaining what they do on a daily basis.
Sometimes we give nicknames, like a little short name to some of the common scenarios we see. And this is a very common one. So this one we give the nickname, Yes Doctor. So they always say, yes doctor, and I do everything the doctor says, but they don't think for themselves at all. They don't look for information, they don't critically appraise information, they don't think about how to put it into practice. They always say, I do everything the doctor says, but they don't actually think for themselves. And if the doctor doesn't say something about health because the doctor is busy and can't think of everything, then they will never think of any issues for themselves. It's quite a common profile.
Yeah, so we present the data back to the frontline practitioners and managers, and we ask the question, how do you work with people like this so they have the best chance of getting and maintaining good health? And they tell us all kinds of things, from all kinds of disciplines in the room. But then we do something rather tricky to them. We ask them, okay, 20% of people in your organisation have a health literacy profile like this. So as managers and organisers of your service or your company, how, in what ways does your organisation meet these needs? Or don't they? For a lot of managers, it's the first time they've seen who they're trying to serve in this way. It's the first time they have a data which explains to them the different subgroups of people they work with on a daily basis. Interesting. It's a very powerful and exciting workshop. Are there any questions?
Thank you. May I introduce myself first? I'm Annie from Technical of Dentistry, Department of Prevalence. I'm a teaching staff. One of our problems is the first step, need assessment. Right? And I think health literacy also can be advocated in oral health. Increased oral health in our community. We have used many of the questionnaires which are related to oral health improvement. But the thing is, there is one thing that usually the community always think that questionnaires are being created and they are tending to fill in those questionnaires for normative information, not the thing that they actually feel or they actually know or what they actually behave, but they think they will answer what we would like to hear from them. Sometimes in the research that we are doing and that we are conducting, it's overestimating the result or whatever is going on in the community. In your experience, how do you overcome those problems?
another excellent question. With any sort of questionnaire like this, you can't always overcome that problem completely. So there will always be some favoritism, but it's easier to overcome the problem to some extent in a questionnaire that has 9 scales than in a questionnaire where you're trying to give a total score, because you're not actually necessarily looking at the whole score and whether they're high or low, but you're trying to compare the scales with each other. Okay? And so people will, if they're trying to also always answer the favourable response, they will try and do that across all of the scales, and so you can see that. But what we really want to know is which of ones are strong or low compared to each other. So that helps a little bit when you have the 9 scales, and you can see, you know, maybe some of the people who are in that group at the top who are all green, maybe some of those people are the people who want to answer positive answers to everything. But having different scales and focusing on the comparison between them does overcome that problem to some extent. Also, there are a lot of things to do with the techniques for how you administer it, and even the wording of the question. So I don't know in Thailand, in Indonesia, I don't know the Indonesian language the way I know Thai, but in Thai language, there's a lot of things that happen in written language that are much more formal. And they make people feel as though they're sitting an exam or they're filling in forms or something, word choices that are quite formal. Okay, in Thai. And then there's word choices that are more like the person just talking to their friends and so on. So in the Thai questionnaire, all the word choices are the least formal option, like just talking to my friends, so that we can tap into, you know, often they're very similar statements to things that they have talked to their friends about. And it gives a feeling of being very informal. Also, some of the questions probably, it's not that easy to pick necessarily what's the desirable direction for every question, because they would be claiming, you know, I'm really, really brave, and they don't necessarily want to make really good claims for themselves about certain issues, and so you can actually pick a little bit from the data. So you need multiple strategies to deal with that, but having the 9 scales certainly helps because you're focusing on the comparison.
Actually, we have done that too by scaling, and they intend to answer the smiling face only or the unhappy face. I mean, they're just, I don't know, it's in our community for dental health or maybe for public health as well. They tend to just answer the greatest one or the minus one. We have done that as well, but with the smiling face and the unhappy face, and having a range of which you feel, I mean which the community feel, and they tend to do that. Yeah, I think that it might be a lesson learned in Thailand. How is it there? Is it quite easy to construct this questionnaire to have a reliable or really capturing what the community need is?
I've described the techniques that we've used, and there's also a lot of testing. So there's a lot of going back and asking people to fill in the questionnaire, and then checking with them what they meant, with hundreds of cases of cognitive testing to see why they gave the answers. Another technique that you can sometimes use, where you get a group to fill in the questionnaire together, is to let them do some practice questions on something else differently beforehand and talk about it, and they see that some people in the group are not just using the endpoints, they're using the middle points as well, and then they're more likely to do it. So there's tricks and techniques that you can use to try and get it, but it's always difficult. But as I said, the 9 scales gives you an opportunity to estimate the extent to which it's actually happening, that they're sort of just going all the good things or not.
Dr. Rita, it's 11:30 now, so how much further should we go with formal presentation and open for questions? Less than 12. Okay, perfect. Excellent. So you can see, if we ask a lot of people a lot of these questions and present their own data, their own patients or community members back to them, we're going to get a lot of information. So each of the dimension by dimension, we can gather very detailed information. So the themes that have come out in Australia from this link to this dimension here, feeling understood and supported by healthcare providers, the ways in which we can intervene in the area of building trust, being patient-centred, care coordination. So from this scale, we can then link the different interventions across each of the scales. So as we have, we can get detailed information. How can we impact on different dimensions in different ways? So it becomes a very detailed set of potential interventions that you can pick and choose given what the problem is. So we don't want every practitioner to apply hundreds and hundreds of these interventions, but it's part of the training and part of upskilling of an organisation to have staff knowing what are the needs of the people they're trying to serve and what are the range of skills which might seem most appropriate in their particular setting. So all these here are gathered from our best frontline practitioners in Australia about their best insights to help people with different profiles. We then also go to the literature. We go to see what has been published in international research to see whether these elements are indeed evidence-based. But sometimes what great frontline practitioners do out there on a daily basis has never been tested, but they keep doing it because it changes people's lives and it works. So the whole range of issues incorporated. Here's another dimension. We have a whole series here of new information about have sufficient information to manage health concerns. Being proactive about health, tailoring and responsive education, having trusted information, accessible information. So I don't want to go into too much detail here, but to say that the local wisdom is systematically gathered and put in a framework so that it's available to healthcare professionals to act on in a whole range of different ways. So feeding up so that we can have a policy which supports organisational strategies, which organise and builds practitioners, and then it supports consumers. A whole systems approach. Are there any comments about that? Please have a microphone.
From the explanation that explained from the beginning, I said that the case that you explained is about and related about public service, health service. How, if we could we use the health literacy for measure habits like food habits, like local wisdom, not related about not related with public service, health services. I mean,
for behaviour change such as for diabetes and eating well, so health promotion activities at home and things like that. Is that what you mean? And also to guide public information sessions and radio and newspaper and communication strategies. Yes.
And how about the item in the questionnaire that mentioned about number one? Can you give me number one? Healthcare practitioner, like that.
Oh, that's the
health
type.
Service, ability to access health service. How about if we may share about the knowledge and the skill about food habit, maybe food habit in the community that not related the accessibility to health service.
Okay, so when I was presenting this in the Public Health Foundation of India, one of the community health promotion managers was saying in his early days of going to a village, a very poor village in India, And he went to one house where there was, the gentleman, the man, he smoked a lot and they drank a lot, and they decided that the traditional diet wasn't any good, and he was, so that whole household had quite a bad, not a good lifestyle and not good health behaviour. The next house, so it's in the same village, same context, same wealth, but that family had decided that, oh no, smoking's not good, and they don't want to drink in this household. And so side by side, in the same context, they had different health behaviour. So what we're seeking to do is to have health literacy questionnaires with all of these people, and you can get health behaviour information as well. So okay, you can be grouping people with all good habits, they smoke a lot or drink a lot, or they have not traditional diet. You can actually subgroup everyone in that cluster analysis and then get a sense of what's the health literacy characteristics there. In the same sort of process then we get with health promotion officers, not medical people, not health people, but health promotion people who've been health communicators for years and years, who've worked in communities, and say, hey, you recognise these people, these different groups in your community. How have you enabled people to do better in their health? Village health volunteers. So in Thailand, there's 900,000 village health volunteers. There's 1 million in India. These people love their villages, love their people, and some are going around doing fantastic health promotion behaviour change. Some have amazing techniques. So we can work with them in this same way, for them to put on the table, for them to show us, what are you doing? What have you been doing over the years that works? So we ask them the question, the right question, for them to be able to share their experiences. So that's how that process can be used.
Even at the very global level, we often make the assumption that what people need, if they're not changing their behaviour, what they need is just more information and more explanation and so on. But this can reveal that sometimes, they may say, I already have plenty of information. They just don't have the social supports to put it into practice. So I don't know the very day-to-day details of how to put it into practice. So it can give you some insights about where the problems lie, and to stop people always planning on giving information when information is just one strategy. And if you work in health marketing, you know that your campaigns need to have complementary strategies at the mass media level and at the community level, and to build and at the individual level through health services. And this can help to document that necessity.
Great question. Thank you. Wonderful question. I guess related to this, and this is sort of beginning to sum up now. So we've talked about all of these in some ways. So the applications of health literacy data. So we can do needs assessment and help build interventions. We can find out who are our patients or our community, what is needed to meet their needs, what are the characteristics of those who do not engage, those who do engage. We haven't talked much about this, but benchmarking and quality. So the tool can be used in across hospitals. So one of the things we've been thinking about in Thailand, or fund allocation across provinces, is based on the prevalence of chronic disease. What's informed by the prevalence of chronic disease. But if you have a province where there's low health literacy, it's going to take more work for health promotion and the medical system to help build the health there. So it's more effort required. So potentially health literacy assessment at a national level can inform resource allocation to hopefully improve equity and health outcomes like that. And then it's very important, interesting to see, as I mentioned before, with maternal health, if we're able to assess the health literacy profile of patients across all the maternal health centres in several provinces, we find out which ones are doing really well with low death rates or low complications, and we can go in and find out what's going on there. Why are they doing so well but then also it can guide us to improvements where there's not good outcomes. Outcomes assessment, the tool is used in many settings to evaluate the impact of interventions designed to improve outcomes. But it's also, a lot of our interventions in public health don't work. The health literacy questionnaires, because it's designed to uncover mechanisms in people. It can provide insight into why interventions don't work and then how you can improve them. So it's used as, say, an intermediate outcome or a moderator in research too. Really cool process to think about. Understanding mechanisms, as I've mentioned. Management and treatment burden assessment, I mentioned that in part. Education and training also. A really interesting process done by a nurse in a small hospital in Australia. He decided, he's a lecturer, a junior lecturer, he decided to give the questionnaire, the health literacy questionnaire, to all of his students, and for the students to interview one patient, and then to calculate the questionnaire score, and then think about, oh, this person has this health literacy profile. Was I expecting that? And so the health literacy questionnaire kind of guides the practitioner of the usual sort of troubles that people have in the community for them to engage in health. So it assists in practitioner training into understand how best to work with their practitioners. That's led on to some other work I'll mention in a minute. Okay. So activities in Asia will be coordinated by focal points. What will focal point do? So a focal point is an organisation, individual, leading activities and supporting activities in a country. So this is getting pretty heavy now, okay? This is, we're ambitious here. So we're seeking to develop a series of strategic projects forming a community of practice and a program of work implemented to improve local and regional health services, health promotion activities and health outcomes through. We would run running training programs that build local capacity and local pride. So here is the first of a training program. People be coming to understand health literacy and the tools that are available. They have to go back to their research setting, their community health setting, their hospital, that use this perhaps new approach. In doing so, they'll reveal local wisdom and local excellence in healthcare and service delivery and health promotion activities, empowering local and regional health workers and managers and policymakers, where locals are developing their own programs, getting their own local pride, and they can share them with the rest of their region or the country. Generating programs to influence key health and development priorities areas such as child and maternal health was spoken a lot today already. Non-communicable diseases, diabetes, hypertension, cancer, heart disease are potential areas to work in. Improvements in health behaviour, the diet, smoking, alcohol intake, as we mentioned. Disease management, medication adherence to TB, and vaccination. How can we get insights to improve these? They're some of the kinds of activities that people may want to do in their health literacy program. Then there's development of interventions that can be efficiently multiplied and scaled up across sectors. And then improvements in education of health professionals and health promotion workers. Nick Roy's grabbed the microphone because he wants to make a comment.
I just want to make a sort of summary comment about all of this that we're just talking about. One issue that often comes up, and it's come up once already in this meeting today, is the issue about whether you should start to drive change from local level or from the top, from the governmental level. And it comes up all of the time. And in many countries, if you look at their projects and programs, you'll find that there's a mix of both and that they never quite manage to meet. So there'll be lots of programs where there's demonstration projects in 20 districts and so on, and this has been run by 5 different universities over a few years. They've all done their own version of it, and it kind of never quite makes its way into policy. Sort of thing. At the same time, there's government level programs which are a loose set of guidelines and a set of performance indicators which are passed down, and they never quite make their way into practice because people on the ground don't actually know what to do in practice. So how do you deal with this sort of strategy for getting this change that's integrated across the health system like that? You can tell that our bias is that the starting point for us that we're interested in is the local level. The reason that our bias is to that is because that makes it into something concrete and demonstrable that you can actually do. But to make it integrated, you need to have two strategies. Okay. The first strategy relates to putting a lot of investment into knowledge management and building communities of practice. So rather than having the same project run in 8 districts and 8 districts and 8 districts by 5 different universities who never talk to each other, but all of that time there's with those projects there's a lot of emphasis put on the different sites sharing with each other and planning how you're going to share with organisations outside, and how you're going to let people who are interested in what's happening in those districts find out about it and become part of the bigger community. So an emphasis on knowledge management and building communities of practice. The second is a matter of choosing the right time to go big. So that as soon as you have some very concrete guidelines and some good examples of practice, then you can go up to the top level, because then when they pass down their guidelines and their performance indicators and so on, it's not just vague. It's like we have all of these concrete examples that you can follow. We've got these manuals and tools that you can use to implement things. And so, our strategy is probably to work local until we have a number of demonstration sites, but make sure that all of the time that policymakers understand what's going on. And then maybe after 1 year, and when you've got very specific activities and things that people are going to be able to copy in their own district, then's the time to choose to try and implement things nationally. So it's just a summary of our overall sort of thinking about that dilemma that many countries find themselves in about the competing of top-down and bottom-up approaches.
There's a microphone behind you.
Pardon my ignorance, but as I kept mentioning, after I've read the focal points that we can do, I think that in Indonesia, people are not very health literate, mainly because they are not fully aware of their health. And I see that maybe the policymakers, as like number 4 says, I think they should concentrate and start from the very fundamental stage. And I'm thinking about education. I'm thinking about starting it at school level, because before I got into medical school, I was very much not health literate, and I realized that that's why I understand why many of my patients don't understand and cannot cooperate with health professionals, because they have different mindset and different knowledge and different priorities. For example, like diabetic patients, most of the time, they know that they have to take the medication. They understand the consequences. They know what medication they should take because the doctor tells them so. But sometimes at the end of the day, they don't take it just because I'm feeling well. I think I should. I think it's okay if I stop taking my medicine. And I feel that I think we really should make them aware of their health before expecting them to be literate. And I was wondering what you have done in Australia, because I have no idea about how do you teach your citizens to be more health literate, to understand more about, to be aware about their health compared to ours. Because I saw sometimes I remember that I watched television and I saw that it's just kid show, and this kid just got played with fire, and they said I got a third degree burn. It's a kid in a Western TV show, and I think that it's the level of health literacy is so much different from here in Indonesia. And I was wondering whether do you do something with your education at school, or how? I just want to know what happens in your country.
But first of all, I don't think Australian health literacy is maybe quite as good as what you say.
Yeah, but
and sometimes when people say I have third degree burns, it's just because they're repeating what the doctor says.
Yeah, because
you're quite right. Like, there's a need to build the underlying level of knowledge about health issues, and schools are obviously very important for the long term to do that, and they can be important for the short term too, because school children go back and they talk to their parents and their grandparents and so on. But the other thing, and this comes back to the issue I talked about focusing on the individual or thinking about the community, is in a village context, you need to understand who can have the influence within that village to lift the level of health understanding in the whole village. And so and that actually varies from culture to culture. So in many cultures, the best strategy to do that is to establish women's groups where sort of mothers and people who are responsible for raising children and buying food and so on, and have an influence about, when other people go to look after health, that they discuss health issues together and that they learn first, and that then spreads out into the community. But that isn't the case in every culture. And so one of the things that I often talk about is whose health literacy is important. Is it the patient? Is it the person who buys food for the family and makes decisions? Is it their peer group? Is it the other men who they talk to at the tea shop or something? Is it the most high status person in their peer group? Is it the village health volunteer? And there's a lot of things we still don't understand, and we would like to study about whose health literacy should we try and influence first in order to lift up health literacy in the whole village.
Yeah, in the village, I think what you mentioned is right. But sometimes it's hard to find reliable people who can actually be someone to look up to follow, to be respect. I mean, because sometimes people who you think you should look up to, and they don't even have the correct, the sufficient level of health literacy, and sometimes they give the wrong message to many of their citizens. And I think that's why I was thinking about education at formal level, so everyone gets the same level of health literacy, and that's why I think that's what really matters. I'm not sure.
We can't do everything at once.
Yeah.
And you're very ambitious, and you must keep your ambition.
Sorry about that.
In Taiwan, there's a national health education program in primary schools, a very strict 10-point program, and with the education department and the physical education department in the government, we built a questionnaire to understand children's health literacy across the country. So virtually every 12-year-old in the country filled in the questionnaire, so I have a profile of the health literacy of children there. This can then be linked to risk factors and to guide curriculum development there. So we're trying to publish that for examples for other governments, because we have to invest in children, because in some ways it's too late when you're an adult, but then it's not in many ways too, because it's about the village, it's about the respect. There's the different people who we can support. So health literacy is about two things, maybe three things. But it's first about it's the individual. What is their responsibility in looking after their health? And how can we support them to take responsibility? So the second part, how can we support them? Irrespective or notwithstanding, it doesn't matter what health literacy a person is. How can we support our health promotion officers, our practitioners, our hospitals to look after people? It doesn't matter what health literacy they have. Now, we have to put systems in place to give them the best chance of engaging in health. So there's two things. Yes, we have to educate the entire population. That's really important. But also we have to put better systems in place so we maximize or we minimize medication errors and procedural errors for childbirth or other things. So that's part of the organizational responsibility as well as the individual responsibility we need to focus on.
I understand that. There's sort of the two issues. How do you improve health literacy, and how do you provide the best care to people who have low health literacy? How do you provide the best care to people who have low health literacy? For some people, you cannot change their health literacy, but you can still give them better care by having, arranging their medicines into little bags for them, or all sorts of, talking to their family and setting up ways to remind them. So you can work around their health literacy problems, even for people where you cannot change their health literacy.
Okay. So we have to wrap up in about 1 minute, but what I'm going to do is just read out some of the activities we're going to be beginning, and hopefully there's lots of partnerships can develop in the room in various ways to support us. So the translation validation of the health literacy questionnaires, it's underway. We're looking to have 6 or more sites where data is collected on individuals, typically in the community. In that way, we can get a large sample size. We can do academic papers and the right statistics to show, yes, the tool is valid in this setting. So that's a partnership. And then there's health literacy of first-year health science students or all health science students. And this is a project where we're trying to understand really what is the health literacy of people studying medicine, health promotion, health communication, and even students in other disciplines who are not related to health. So, because so many, as an educator, as a professor, we're trying to give our students the best chance of finishing their degrees, to get back out to the community to make a contribution. Because our universities get paid by how many people complete the course, but not by the dropouts. So developing better programs for student welfare. And then what makes your organisation a health literacy organisation? So there's potential for to get surveys of wonderful, detailed ideas from managers about how they've made the organisation work nicely, and potentially about how can health literacy data be used to inform disease prevention, quality and safety, and potentially for cost saving. Let's try to find out ideas from the communities, from experts, about what's the value of health literacy surveys so that we can have good documentation to support academics to go for grants and develop a program of research here, and so that we can bring in external funds from larger NGOs to develop a program, even from the Australian government, from AusAid or EFAC, as it's called now. And then really local regional development, be really a process. Having communities of practice, several sites doing what they need to do in the workplace or in the hospital or in health promotion settings to develop really sensible local wisdom, using the local wisdom for effective programs and sharing the knowledge. So that's why we're here, is to tell you all about the methods and the opportunities to help use this process, these methods, to improve health promotion and public health outcomes, and ultimately, why we're here is to prove equity. So that's the end of the formal conversation we've had with you. It's been a conversation today, not just a lecture. It's been fantastic. So I'll hand over to Dr. Rita to do a wrap-up or facilitate questions or whatever's required.
Okay, let's give applause to Pak Richard and Pak Roy. Do you still have questions before we move on to the training after lunch? Okay. Please mention your name and then what organization.
Sorry. Firstly, I'm really pleased to join your lecture today. And then second, I will introduce myself. My name is Sigit. I'm coming from Department of Geography. I'm still learning about the topic of geography, but the concern only the location. Based on your presentation, firstly, I get it. I know there is different approach for health literacy for developed country and developing country. And then in developing country like Indonesia, we have so many different cultures and then languages and local wisdom. So this is not I think this is not only difficult, but we can take an opportunity like challenge for us as academics and others. And then maybe in Australia as a developed country it's easy. But I have a question for you all. As we know, in Australia there is the special ethnic is Aborigine. So how you doing approach about the health literacy for them? Because I'm not sure that Australia as a developed country and then you also easy to approach the literacy for all people and then they can respect, they know about your promotion. But how about the Aboriginal community? You're doing an approach like that. I think enough. Thank you.
Thank you very much for your 14 questions then. Lots of questions, really good questions. So I may miss a couple because with the Aboriginal people, we're working with one community now and to build strengthening in the local community. It's very important with Aboriginal people that they build it themselves. The model for health literacy we have here is very much part of Aboriginal culture, and it's sitting down and talking about what's going on. I had the privilege, the honour to go into very far north Queensland, into the Cape area, actually not far down from Papua New Guinea, really, and able to meet some Aboriginal elders, some of the tribal leaders, and they know the solutions. They know what they know. They have horrendous, terrible health problems, so terrible. But the elders, they know what the solutions are, but they've never been asked the question about what to do in the right way. They have local solutions. They have local wisdom now. So we're hoping to slowly work with the Aboriginal communities for them to make their own solutions about health literacy. It's not always about the idea of health literacy. It's about how to change services, how to empower people, how to stop the alcoholism, how to stop the petrol sniffing, how to do things like that. In some Aboriginal communities, there's big solutions, wonderful solutions, so we can ask the right questions to find out why it's worked in other places and not in others. In New Zealand, with the Aboriginal people there, they're using the Health Literacy Questionnaire as a quality and monitoring tool of their current programs that are being delivered by Aboriginal peoples. And that's a national program coming there. So that's one of the questions you asked. Can you remember another?
I want to talk a little bit about the issue where you have many cultural groups and many languages. First of all, we're not very much more advanced in all of this in Australia than in other countries. We have started to work in other countries straight away. And part of the reason for that is we don't want to just assume that all Australians are the same. We want to sort of learn from people from very diverse backgrounds within our country as well, by working across countries and being culturally sensitive in everything we do from the start. One of the advantages in working locally and then trying to build up the picture of good practice from there is that you don't need to if you start with a top-down program and then you have to sort of translate it into every language in Indonesia and make it fit into all of those different languages. Starting bottom up, you can work with 4 or 5 different language groups within Indonesia and then ask the question, what are the similarities and differences between these groups? And then that helps you inform other groups that are likely to be interested, and they can see which ones they are similar to, which ones they are different to, and can build up their own practice in that way. And you can start to build up which of the things are common across all of the groups in Indonesia because of the common culture and the common health system requirement, and which things are different and that we really need to handle in a different way and think about uniquely for each group that we work with.
Okay, I know we have just a lot of questions more about how to implement this health literacy questionnaire. But we will continue with the training session. So you can ask a lot of things, and then Pak Richard and Pak Roy already offering us how to involve in health literacy questions in Indonesia. So let's talk more details in the training. So I hope that all of you can join the training. Okay, we will have a break until 1 o'clock, and then unfortunately we cannot providing you lunch. So you can have lunch in the Sugeng cafeteria here, or in other place that you prefer to have your lunch. But we will meet at 1 o'clock in the next room for the training. So it's ruang guru besar. So it's the next door. Yeah. Okay. So let's give applause to all of us. Yeah. And we will meet again at 1 o'clock. Thank you, Pak Osborne and Pak Roy. Iya, sertifikatnya ada 2. Yang satu adalah seminar. Seminar silahkan bisa diambil. Untuk yang training